So I just told a joke on a Microsoft Teams meeting that I had. It was not even remotely funny. But I know I'm equally not funny in person or on video, but I keep trying. But all joking aside, in this lecture, we'll talk about communication in healthcare and the serious consequences of failed communication. Now, take a moment to really look at this slide. Every year in the United States, over 100,000 patients die because of medical errors. Not disease, not trauma, but errors, mistakes that happen in the system of care. So, to make this number real, 100,000 people is more than enough to fill both of these stadiums because InfoCision Stadium seats about 30,000 people and the Cleveland Browns First Energy Stadium seats about 67,000 people. So imagine these two stadiums full of people, every single seat full. So now imagine every single one of these people are gone in 1 year due to preventable errors. That's the magnitude we're talking about. And here's the part that should make every one of us in healthcare really stop. 72% of these errors are linked to communication failures, not lack of intelligence, not lack of caring, not bad intentions, communication, which means how we speak, how we listen, how we hand off information, how we clarify, how we document. These things literally save lives or cost lives. So when we talk about things like ISBAR or closed loop communication, when we practice giving report, we emphasize speaking up, and this is why. Because good communication is not a soft skill, it's a life-saving intervention. So as future nurses, you're going to be at the center of nearly every communication chain in the hospital. So I want you to remember these stadiums when you give reports, when you catch a medication error, when you advocate for your patients, when you repeat something that didn't sound quite right, because this is the difference you make.
I want to share with you the story of two very important, very real, and very loved faces in patient safety. One, the precious young face of my newborn son, Cal, and the other, the face of my late husband, Pat. Cal was born a healthy baby boy on March 23, 1995, in a large, accredited hospital that delivers over 5,500 newborns a year. Cal was first noted to be jaundiced through visual assessment at 16 and a half hours old, but a bilirubin test was not done. Cal's skin was described to be jaundiced again through visual assessment when he was 23 hours old, but a bilirubin test was not done. Cal was discharged from the hospital when he was 36 hours old and was described as having head-to-toe jaundice, but a bilirubin test was not done. The information we received about jaundice was a simple brochure that never mentioned jaundice could cause brain damage. We were told to put Cal in the window for sunlight, not to worry, and to call the newborn nursery or our pediatrician if there are any changes in sleeping, eating, or any other behavior. On day 4, I called the newborn nursery and told them that Cal was still yellow, lethargic, and was feeding poorly. They asked me if I was a first-time mom, and then assured me there was no concern since sleepiness was to be expected. They told me to unwrap him and tickle his feet, and if that didn't work, to call the pediatrician. We immediately took Cal to the pediatrician, and he noted the jaundice by visual assessment again. A bilirubin test was not done. We were told to wait 24 hours to see if he would improve. We continued to call the pediatrician throughout the next 24 hours, reporting that our child was changing before our eyes. Yet we were repeatedly told not to worry and to wait for 24 hours. At 5 days of age, the pediatrician admitted Cal to the pediatric unit. Cal's bilirubin was tested for the first time, and it was one of the highest recorded bilirubin levels at the hospital. Treatment was limited to phototherapy. Again, we were told not to worry. A resident did Cal's history and physical upon admission, and due to confusing chart entries, documented the wrong blood type for Cal. A blood incompatibility was ruled out. We later found out that Cal's jaundice was due to a common blood incompatibility and was very easy to treat. On day 6 in the afternoon, Cal had a high-pitched cry, respiratory distress, increased tone, and he started to arch his neck and back. These behaviors were all acute symptoms of kernicterus, or brain damage from jaundice. Again, we reported the unusual behavior to the providers and staff, and again, we were told not to worry. Cal was later diagnosed with classic textbook kernicterus. Cal has athetoid cerebral palsy throughout his entire body, neurosensory hearing loss, enamel dysplasia on his front teeth, crossed eyes, and other abnormalities. Today, Cal cannot walk independently, his speech is impaired, he drools, and he has uncontrollable movements of his arms and legs. In 1999, my husband Patrick, who was a face of panache, ambition, confidence, and strength, also suffered a medical error. It was discovered that Pat had a mass in his cervical spine, and because of the size, shape, and behavior of the mass, it was thought to be a slow-growing benign tumor. With the help of our local referring doctor, Pat and I sought out the best neurosurgeon in the nation. The tumor was surgically removed, and a frozen section was sent to pathology. A phone call from pathology to the OR revealed an atypical spindle cell neoplasm, which was understood by the OR team to be benign. The pathologist, however, believed it to be very suspicious and ordered more stains to further define the tumor. 21 days after the date of surgery, a final pathology report was issued as a malignant synovial cell sarcoma. The report was apparently sent to the surgeon's office, but was either filed without the surgeon ever seeing it, got lost, or was misplaced. The cancer was never communicated to Pat, our local referring doctor, or me, and it went untreated for 6 months. Pat's neck pain returned, so we went back to the neurosurgeon to find that the tumor had grown to the size of the surgeon's fist, had spread, and had invaded his spinal cord. Upon removal and a pathology, it was again diagnosed as a sarcoma. Pat's chances to survive his cancer were reduced dramatically by the communication failure. After 7 surgeries, 9 months of chemo, and several rounds of radiation, Pat died. Both Cal's and Pat's errors are examples of simple yet catastrophic systems failure due to communication breakdowns and uncoordinated teamwork. Cal went through several layers of the healthcare system, and each layer failed to stop the succession of error. There was a system-wide failure to include Pat and me in Cal's care. This was not any one individual's failure, but at any point, one individual could have made a difference by stopping the systemic failure before it reached its tragic conclusion. What if a genuine culture of safety that practiced a systems-based approach had been in place? What if our concerns as parents were taken seriously and we were asked to work in partnership with Cal's providers to help identify jaundice symptoms? We, parents, patients, and family members, can be additional eyes and ears to spot symptoms. We can be an extra resource to see, feel, recognize, and report changes and concerns. What if the pathologist had given the surgeon a heads up that Pat's tumor was suspicious and that they had ordered additional tests? Or if someone had contacted the neurosurgeon to ensure the receipt of the malignant pathology results? Or what if the pathologist and the neurosurgeon understood the phrase atypical spindle cell neoplasm to mean the same thing? As a family, we are profoundly let down by the very system that we once trusted implicitly. With this in mind, I ask you to never give up on patient safety.
Research shows about 70% of our total waking time is spent communicating in some way. So whether we realize it or not, we are constantly exchanging information with patients, our peers, families, providers, and even ourselves. But what's really surprising is how that communication breaks down. So only about 9% of our time is spent writing, including things like charting, documenting, or texting. Another 16% is spent reading. We might be reading patients' charts, orders, policies, or hundreds of crazy Kahoot questions. Only 30% of our communication is spent talking. So yes, we're talking, explaining, giving instructions, but that's not the majority. The largest chunk by far is listening. Almost half of our communication time is spent simply listening. Listening is the most used communication skill in healthcare, but it's the least taught. We train how to speak to patients. We train how to document. We train how to give report. But do we train ourselves to listen, to slow down enough to understand, to hear what's being said and what's not being said? In nursing, listening is an intervention, just like administering medications, assessments, or wound care. When we actively listen, we improve safety, we build trust, we catch errors, and we prevent harm. So as we move forward into communication skills, I really want you to think about your own listening habits. The strongest communicators are not the best speakers, they're the best listeners. The transaction model of communication is the model we use in real-life interactions, especially in healthcare. So in this transaction model, communication isn't just one person talking and the other person listening. Instead, both people are sending and receiving messages at the same time. So think about a conversation with a patient. Even when you're talking, you're also reading their facial expressions, their body language, and their tone of voice. And they're doing the same with you. So conversation is not one way, it's a mutual exchange. So on the slide, you see 2 heads, one labeled encoding and the other decoding. Encoding is when we take our thoughts and turn them into words or gestures. Decoding is when we interpret what the other person is saying. The problem is that the meaning is not automatically shared. Meaning is something we co-create together during the interaction. That's what the arrows in the center represent. When we talk about noise, we're not just talking about loud sounds. Noise is anything that interferes with the message, disrupting the co-creation of meaning. So things like stress or pain or cultural differences or language barriers, assumptions, or even just being in a chaotic environment. So for example, if a patient is scared or in pain, they may literally not hear your discharge teaching, even if they appear to be listening. Their internal noise is competing with your message. So communication is always happening within different contexts, and contexts do matter. Physical context is where you are. Are you in a noisy hallway or in a quiet room? Psychological context, consider things like emotions or stress levels or where is somebody's mental state. Cultural context is about beliefs, values, and communication norms. Relational context is the relationship you have with that person, and trust level does matter. So communication is not just talking, it's the shared process of creating understanding. So that's why listening, asking clarifying questions, summarizing, and checking for understanding are critical nursing skills. So we know that conflict happens, misunderstandings happen. It's how we handle these moments that matters a lot, especially in healthcare. So this cartoon pretty much shows what not to do. So the manager says you should check your emails more often. I fired you over 3 weeks ago. Obviously, that's extreme, but it makes the point. Important, emotional, or conflict-heavy conversations should not be handled over text or email. When we try to address conflict through messages, we lose tone, facial expression, empathy, all the things that help humanize communication. It's really easy for messages to come across colder, harsher, or more aggressive than we intended. So in-person communication allows for tone of voice, body language, immediate feedback, clarifying questions, and that human connection. All of those things can completely change how the message is received. So if there's tension or confusion or a problem brewing, handle it face-to-face whenever possible. If in-person isn't an option, then a video call or phone call comes next. So the takeaway is the more emotional the message, the more personal the method of communication needs to be. So there are 5 key qualities we should aim for when we communicate, especially in healthcare where misunderstandings can seriously impact patient safety and team function. First is complete. This means sharing all the necessary information, not leaving pieces out, not assuming the other person already knows, and not making them guess. If it's relevant, include it. Next is clear. We want to use plain language. We don't need complex terminology to sound smart. We need to clarify to keep patients and teammates safe. Say things in a way that people can easily understand on the first try. Then there's brief. This doesn't mean rushed or super short. It means getting to the point. Focus on the important information so others don't have to sift through all of the extra detail to find what matters. Then there's timely. Communication isn't just what we say, it's when we say it. If information is delayed, outdated, or shared too late to act on, it loses its value. Sharing information in the right time frame keeps the whole team aligned. And finally, respectful. This one is huge. Respectful communication shows psychological safety. It says, I value your role here. I am listening to you. I respect your time and your contributions. This builds trust, and trust leads to better teamwork and better outcomes. So complete, clear, brief, timely, and respectful. These are the 5 principles that create communication that works. We talk a lot about what we say, but what about what we don't say? Because nonverbal communication, our expressions, our posture, tone, eye contact, often says more than our words. And if there's an incongruency between someone's verbal and nonverbals, which one will be believed? It will be the nonverbal every single time. So we need to be honest about the fact that communication is not always easy. There are real challenges that can get in the way. There can be language barriers. Not everyone we work with or care for shares the same primary language. That can lead to misunderstandings unless we slow down, clarify, or use interpreters effectively. Then there are distractions, stress, and fatigue. These are huge. When we're overwhelmed, tired, or pulled in multiple directions, we simply don't listen or express ourselves as clearly. Sometimes it's not the message that was unclear, it is that our brains are overloaded. So then there's physical proximity. Communication changes depending on whether we're face-to-face, calling from another unit, or leaving notes for the next shift. Proximity affects connection and clarity. Then there are personalities. We all know some people are direct, some are quiet, some are emotional, and some are very factual. Personalities shape how we express ourselves and how we receive communication. Then there's workload. When workload is high, communication tends to get rushed. And when communication is rushed, accuracy drops. People have different backgrounds, vocabularies, and priorities because everybody brings different experiences to the workplace. What makes sense to one person might be confusing to somebody else. We can't assume shared understanding, we have to check it. Then there's varying communication styles. Some people send long messages, others use one-word responses. Some prefer to talk, others text. None of these are wrong. We need awareness to avoid misunderstandings. Then there's conflict. When conflict is present, many people shut down, get defensive, or avoid the conversation altogether. That makes resolution harder and builds tension instead of clarity. Lack of information verification. So this is basically when information gets passed along telephone style without confirming accuracy. That is how mistakes happen, especially during handoff reports. And then finally, shift changes. So we all know this is the perfect time for information to get lost. That's why structured handoff communication is so important. So communication takes conscious effort. It doesn't just happen. We have to be aware and intentional and willing to check for understanding, especially when things are chaotic. So I want to introduce you to something called Team Steps. Team Steps stand for Team Strategies and Tools to Enhance Performance and Patient Safety. It's a national evidence-based program developed to improve teamwork and communication in healthcare. So the main idea is that no one works alone in healthcare. And when communication breaks down, patient safety is at risk. So Team Steps gives us practical communication tools we can use every day to keep patients safe and support each other as a team. So we're going to talk about some key information exchange strategies that come directly from Team Steps. We'll talk about things like ISBAR, callouts and checkbacks, and handoffs. These strategies help us communicate on purpose, not by chance. They reduce errors, improve teamwork, and keep patients safe. SBAR, or the extended term ISBAR, is a structured communication framework that helps us share information clearly and effectively, especially when something is changing with a patient or when we need to call a provider. It helps us keep focused, organized, and avoids the rambling phone call situation where everybody leaves confused. So breaking down each step, we start with I for introduction. So this is where you quickly state who you are and why you're calling. So for example, hi, this is Taylor, the RN on 4 West, calling about Mr. Jones in room 418. It helps immediately orient the person on the other end. Then there's S, the situation. Here we explain what is going on right now. What triggered the concern? Something like, his blood pressure has dropped to 88/54 and he's complaining of dizziness. So this sets the stage. Then there's B for background. We give clinical context that helps make sense of the situation. It includes history, recent labs, or relevant conditions. So for example, he was admitted for sepsis yesterday and has been on IV fluids since admission. Not every detail, just what matters. Then there's A for assessment. This is your clinical impression. What do you think is happening? It's okay to have a hypothesis even if you're unsure. So for example, I'm concerned he might be getting more hypotensive and needs additional support. Providers expect your assessment. It helps guide their thinking. Then we have the first R for recommendation or request. So this is the part where many students forget to advocate. What do you need? What do you want them to come assess the patient? Do you want a new order? Say it directly. I'd like to request an order for IV fluids and ask you come evaluate him. A clear ask can lead to a clear action. And the last R is read back. So after the provider gives orders, you repeat back to them to ensure accuracy. This prevents miscommunication, especially over the phone. So for example, okay, I will give 500 milliliter bolus of normal saline now and recheck the blood pressure in 15 minutes. Is this correct? This closes the loop. So SBAR or ISBAR ensures both sides are on the same page and prevents patient harm. So now you'll take a look at a video on SBAR.
Bonsu, this is Laura on 3A. I have your patient Mary Smith in 3A12. Her date of birth is 12/5/49.
Hi, Laura. How can I help you?
Well, we have a situation. She decided to get up out of bed without using her call light, and she fell. It was an unwitnessed fall. She does have a large hematoma on her forehead, and I went in the room and assessed her and got her back to bed. Her background is she was admitted with abdominal pain and increased confusion. I came on shift at 7 this morning, and she is becoming more confused and a little more agitated. When I assessed her, she's only alert to herself now. Her pupils are equal and reactive. Her vitals are good. Her blood pressure is 106/76. Her pulse is 96. She's 98% on room air and her respirator 18. She is complaining of pain to her head, 8 out of 10, and her urine does have a strong odor and it's dark and cloudy. I would recommend a CAT scan of her head, neuro checks every 4, and a sitter. What do you think we need to do?
I totally agree with your recommendations. Let's get the CT of the head, the urinalysis, Q4 neurochecks, and also get a sitter for the bedside. I will come there as soon as possible to assess this patient and order any further tests that will be necessary. Do you have any further questions?
No, I think I'm good. I'll call you as soon as we get the results of the CAT scan. Thanks. Bye.
Thank you.
So now let's talk about two very important communication techniques we use all of the time in healthcare, the call out and the check back. A call out is when we verbally announce critical information out loud so the entire team hears it at the same time. This is especially helpful during fast-paced or high-stress situations, like codes, rapid responses, or in the OR. So for example, blood pressure is dropping, now 82/46, or we need a crash cart now. It's quick, loud, and clear. This helps everyone in the room stay on the same page and anticipate what's coming next. So next is the check back, or repeat back as it's also known. This is how we make sure a message was actually heard and understood correctly. It's part of the closed loop communication. So here's how it works. The sender states a message, such as, give 2 milligrams of morphine IV, and the receiver repeats back 2 milligrams morphine IV, and the sender confirms correct. This prevents dangerous mistakes like incorrect doses, wrong medications, or misunderstandings. So the call out tells the whole team what's happening, and the check back confirms that the information is accurate. So both help reduce communication errors. And as we've been talking about this the entire time, communication errors are one of the biggest contributors to patient harm. So we'll first have a video on call outs, and then we'll have a video on check back.
Again, will you record?
Yes.
BP is 160/90. Respiratory rate is 28. Heart rate is 130. Pulse ox is 87% on 2 liters. Olivia, please get the non-rebreather from the cart. Jay, please call 911. Tell them we have a possible MI or PE.
Calcium gluconate diluted in 100 milliliters of normal saline IV for an hour.
To confirm that, 1 gram calcium gluconate diluted in 100 milliliters of normal saline IV over an hour?
Correct.
So a handoff is when care responsibility transfers from one nurse or provider to another. It could be at shift change, unit transfer, or sending a patient to a procedure. It's one of the most critical moments in patient safety because handoffs are high-risk moments. If we don't communicate clearly, important details can be lost, and that's when errors happen. So we can use standardized tools like SBARS or IPASS or electronic report templates to make sure that we're giving complete and consistent information. So these tools aren't just extra paperwork, they're patient safety tools. So some key practices during handoff include minimizing distractions. So this is not the time for phone scrolling or chatting about the weekend or trying to multitask. The patient deserves our full attention during the handoff. We want to make sure that we allow time for questions. The person receiving the patient should be comfortable asking, can you clarify? Or what is the plan if we rush, we miss things? We want to encourage two-way communication. Handoff is not a one-sided speech, it's a dialogue. So instead of, here's your patient, bye, it should sound more like collaboration. So here's an example. So the nurse giving report. So the patient is stable, but they had a blood sugar of 62 this morning. I treated it, then it came up. Here's the current plan. The nurse receiving the report. Got it. I'll continue monitoring and recheck during my shift. Any concerns about intake? Nurse giving report. Yes, encourage snacks. Let me know if they trend down again. So this back and forth helps keep patients safe and helps you walk away from your shift feeling confident that you've given the next nurse the tools that he or she needs to be successful in caring for the patient. So one example of a handoff tool is IPASS. IPASS is a widely used standardized framework that helps us hand off patients clearly, efficiently, and safely, especially during shift changes or transfers. So the goal is consistency. We don't want to rely on memory alone or hope we remember everything. We follow a structured, repeatable pattern. So the I is for illness severity. So this is a quick classification of the patient's status. Are they stable or unstable? It helps the receiving nurse immediately understand the level of urgency. The P is for patient summary. So this is your concise story of the patient, why they're here, what's happened so far, their current status, and any important past medical details. Think of this as the headline, not every detail, just what matters. Then A for action list. So this is a to-do list. What needs to happen next? What are the priorities? Who's responsible? This keeps care moving forward smoothly. The first S is for situation awareness and contingency planning. So this is where we say, here's what we're watching for. So if X happens, do Y. This prepares the next nurse before problems occur, preventing panic or confusion. And then the last S is synthesis by the receiver. So this is where the receiving nurse repeats back what they heard. They ask questions, clarify, and restate the key points. This is crucial because understanding needs to be confirmed, not just assumed. So why IPASS works better than standard scripts is because it makes report more efficient. It reduces mental load for both the sender and the receiver, and it avoids misinformation. It reduces unnecessary backtracking or extra work. So instead of feeling every handoff is guesswork, everyone knows exactly what to cover and what they will hear. So the more consistent we are with handoff tools like IPASS, the safer our patients are, and the smoother our transitions will feel as a whole. Okay, so I know you guys know who these cute little critters are, and you know what the answer is to this question. So guys, what's gonna work? Teamwork. So take it from the Wonder Pets. Teamwork is the core of patient safety. No one saves the day solo. So teamwork means we share the same goals, safe, timely, and compassionate care. We use the same playbook. The IES bar for updates, call outs for critical information, checkbacks to close the loop, and structured handoffs like iPass. We create psychological safety because if we speak up, ask for help, and thank people who raise concerns. And finally, anticipate together. So if X happens, we'll do Y. It's all about contingency planning. So once again, what's gonna work? Teamwork. So let's talk about the difference between a group and a team. You'll hear the words used interchangeably, but they're not exactly the same thing. So on the left, we have groups. A group is simply a collection of people who are around each other and may influence each other, but they don't necessarily have a shared goal. So this could be classmates who always sit together, people you walk in from the parking lot with, or lab partners who really don't coordinate anything. They just happen to be doing the same task in the same space. And yes, sometimes groups have vibes, like our closed off body language gang here. They have their arms crossed, same energy, they don't have to say a word, you get the message. They are influencing each other, but they're not necessarily working collaboratively toward a shared outcome. On the right, we have teams. A team is also a group of people, but the key difference is that everyone depends on each other to meet a shared goal. So in a team, we have a common purpose. We coordinate. We rely on each other's strengths. One person's success is tied to the success of the entire group. So for example, we have our Nursing Leadership and Practicum Project Team 7. They have to collaborate. If one person doesn't do their part, the whole team feels that they're interdependent. So a group is a bunch of people together, while a team is a group with a shared purpose and shared responsibility. So in healthcare, we really need teams, not just a group of individuals who happen to be in the same building, because teamwork saves lives, reduces errors, and produces patient outcomes and safety. Healthcare doesn't run on just one team, it runs on multiple teams that overlap and interact around the patient. So at the very top here, we have the core team. These are the people who are directly involved in the day-to-day patient care. So this includes the patient and their family, the bedside nurse, the case manager, the physician or provider. The core team has the closest contact with the patients. They're the ones continually assessing, communicating, and making decisions to support the patient's immediate needs. Then there's the contingency team. They step in during specific or urgent situations. Think of teams like rapid response teams, code blue teams, disaster or mass casualty teams. These teams aren't always operating, but when something unexpected happens, they activate quickly to support or take over care for that moment. Then there are coordinating teams. This team oversees the environment where the care is happening. So people like charge nurses and nurse managers or patient flow or resource coordinators. They're not necessarily at the bedside, but they're the ones making sure the unit runs smoothly, assigning staff, allocating resources, managing admissions and discharges in the overall patient flow. So then there are teams that provide support behind the scenes. So first we have ancillary services. These are professionals and technicians who provide specialized services that support diagnosis and treatment. These include things like diagnostic services, radiology, lab, imaging, and pathology. And then there's therapeutic services like physical therapy, occupational therapy, respiratory therapy, and speech therapy. These team members aren't always at the bedside, but their roles absolutely influence a patient's diagnosis, treatment plan, progress, and recovery. Next, we have support services, which are often overlooked but are truly essential to safe and efficient patient care. These are non-clinical healthcare workers who keep the environment functioning. So examples include environmental services, who maintain cleanliness, infection control, and a safe environment. Transport, who move patients from tests and procedures. Food services, who ensure patients receive meals and meet diet orders. And central supply, who make sure equipment and supplies are available when needed. And finally, at the base of a multi-team structure, we have administration. This includes those individuals responsible for the overall direction and functioning of the organization. So administration provides strategic, financial, regulatory, and operational oversight. So meaning they are making decisions about budgets, staffing levels, accreditation requirements, safety standards, and long-term goals. They also hold 24-hour accountability for what happens in the organization. So when a unit is short-staffed, when new equipment is needed, when policies need to be changed, or when a crisis occurs, administration is the group responsible for ensuring the hospital can respond effectively. So another really important role they play is in establishing the organizational culture. So they set the tone for what the environment feels like, whether collaboration is encouraged, communication is open, and whether staff feel psychologically safe to speak up. They also develop policies and procedures that create the systems and pathways that allow staff to access resources, whether it's education, equipment, support services, or escalation chains. So even though administration may not have direct patient contact, their work supports every team above them in being able to deliver safe, efficient, and patient-centered care. How teams function is based on the Homans framework. So this framework helps us understand what makes a team work well or not so well. There are 3 essential elements. The first is activities. These are the observable behaviors of the group members. This could include things like who speaks up, who takes notes, who does the hands-on work, basically what people are doing. Then there are interactions. These are the verbal or nonverbal exchanges between members. So it's not just what is said, but how it is said. Tone, body language, even silence. Good interactions build connections. Poor interactions can create conflict or confusion. And then there are attitudes. So these are the perceptions and feelings and values held by members. Do people like being here? Do they trust one another? Attitudes drive the culture of, or the vibe of the group. When we look at how effective a team is, we measure 2 things. We measure productivity, or how well the group uses the resources to get the job done. This is the outcome side. Are we achieving the goals in a reasonable way? And then there is cohesiveness. So this is the degree to which members are attracted to the group and want to contribute. A cohesive team supports one another, communicates openly, and works towards shared success. So teams don't start out functioning perfectly. They develop over time. There's a predictable pattern that most groups go through. It's called the forming, storming, norming, performing model. Forming is the getting to know you stage. People are polite, a little cautious, and still figuring each other out. No one wants to step on toes yet. Members gather and look for where they fit in. People are careful in how they interact. The group tends to heavily lean on a leader for direction. Tell us what we're doing, how we're doing it, and why. So think of that feeling on the first day of clinical when no one wanted to talk first. That's forming. Storming is now the honeymoon phase ends. This is where conflict can show up. Members may disagree on tasks, goals, or roles. Personalities can clash and people may compete for influence or leadership. This stage is normal, not a sign that the team is failing. In fact, if you never have storming, it often means people are suppressing important conversation. The leader's role is key here. Help the group name the conflict, talk through it, and guide members towards a resolution that benefits the whole team. Norming, this is where things start to click. The group sets shared goals and expectations. Roles and responsibilities become clearer, trust builds, and cohesiveness begins to grow. People shift from thinking me to we. This is the stage where the team starts to feel more comfortable and work together instead of side by side. Performing is the stage where the team actually produces work. Things are going smoothly. Members understand the purpose, tasks, and their roles. Cooperation is high, trust is formed, and emotional tension is low. The leader shifts from directing to supporting, providing feedback, and helping maintain momentum. This is the stage where you look around and think, wow, we're really functioning as a real team. Adjourning happens when the work is done. The team dissolves after meeting its goal. Some people might feel relieved, feel accomplished, or even some sadness if the group bonded well. Then there is a reforming stage. This stage happens when something big changes. A new member joins, a key member leaves, the task or the environment shifts. So when this happens, the group has to revisit earlier stages, often going back to the forming or storming temporarily while roles and relationships reset. So teams don't walk through the stages once. They cycle as conditions change. So a high-functioning team isn't something that we're given. It's something that we develop, protect, and rebuild as needed. So norms and compliance are basically the unwritten rules of how we do things in a group. So norms are not official policies. Nobody writes them down or announces them, but everybody knows them. They're informal rules that guide behavior, tone, expectations, and how the group operates day to day. So some examples you've probably seen is we always text in the group chat before we leave clinical, or we divide projects evenly, no freeloaders. Or we sit in the same seats every class without anyone ever having to say that they are assigned. Norms keep the group running smoothly. They support stability. They help avoid chaos, and they create a sense of predictability. Groups survive because norms are enforced. If nobody follows the norms, the groups fall apart pretty fast. So what happens when somebody doesn't follow the norms? So there's typically stages the group will move through. They'll provide rational argument because the group wants to start nicely. So, hey, could you turn your part in on time so we could all look at it? Then they move to persuasion or manipulation because the tone shifts slightly. If you don't turn it in today, we can't move forward, and we really don't want a bad grade. If that doesn't work, there's often an attack. Now it's spicy. We're doing all the work. Why aren't you? And if this doesn't work, then it comes to a point where the group starts ignoring the individual. They stop trying, which means the person is basically socially removed from the group dynamic. So this is how groups protect themselves. And it's exactly why some groups feel tight and supportive and others feel tense and dysfunctional. So situation monitoring is a core team steps skill, and it's exactly what it sounds like, keeping our eyes open and our brain engaged. Because in healthcare, things can move fast. Situation monitoring means we are actively scanning what's going on around us rather than just focusing on our own task. So it's not just doing your job, it's doing your job while staying aware of the bigger picture. So this helps us notice changes early, prevent errors, and allows us to jump in when a teammate needs help. Situation monitoring is important because no single person can see everything happening with a patient at all times. When everybody is watching the situation together, we create a safety net. This leads to mutual respect because we're looking out for one another. Team accountability because we don't let someone struggle quietly. And better patient outcomes because issues are caught earlier before they become emergencies. So situational awareness is basically your ability to understand what is actually happening around you and not just what you assume is happening. And as again, healthcare, things change quickly. Patients can decline, priorities shift, team members get pulled to other tasks. Situational awareness means we don't just put our heads down and do one task, we stay aware of the whole picture. So we are paying attention to the patient's status. Are they improving, declining, in pain, confused? Maybe their vitals have changed or their behavior has changed. The status of team members. Who needs help? Who is overwhelmed? Who is covering what task? Then there are environmental conditions. Are there disruptions, safety hazards? Is equipment missing? Is the room too loud for safe communication? Then there's progress towards common goal. Are we moving forward or are we stalled? Does something need to be prioritized? So situation monitoring is the act of constantly scanning. Situational awareness is understanding the situation. So you're passing meds and your patient starts breathing faster, sweating, and then they say, I don't feel right. Situational awareness is you pausing, noticing the change and calling for help instead of just finishing your med pass because you're focused on the task. So situational awareness is not automatic. It's something we have to actively work at. And it's strongest when everyone on the team is communicating and staying aligned. So to maximize situational awareness, we need to share information openly with our team. If you see something concerning, don't assume somebody else noticed. Say it. Request information when you need it. If you're unsure or missing details, ask because silence leads to errors. Direct information to the correct person. Saying somebody should help this patient is vague. Saying, Sarah, can you grab vitals is clear. Include patients or the family when appropriate. They often know the patient's baseline better than we do. So use tools available. They exist to help us stay updated and coordinated. Keep documentation accurate and timely because if your documentation is behind, your team is working with old information. Know where to focus attention. Not everything is equally important. Prioritize what affects patient safety first. And know the plan and update it when things change. A plan is only useful if everybody is on the same page. And finally, tell the team when the plan changes. So if a change in orders, a change in condition, or a new priority needs to be shared immediately. So let's take a look at a video as an example of situational awareness.
Again, this is the USS Montana requesting that you immediately divert your course 15 degrees to the north to avoid a collision. Over.
Please divert your course 15 degrees to the south to avoid collision.
This is Captain Hancock. You will divert your course. Over.
Negative, Captain. I'm not moving anything. Change your course. Over.
Sir, this is the USS Montana, the second largest vessel in the North Atlantic Fleet. You will change course 15 degrees north, or I will be forced to take measures to ensure the safety of this ship. Over.
This is a lighthouse, mate. It's your call.
A shared mental model basically means that everybody on the team has the same understanding of what is happening, what the plan is, and what is expected. It doesn't mean that we all do the same task. It means we all have the same picture in our heads of what is going on. When everybody understands the situation, the plan, and the goal, care is synchronized and we move together instead of working in conflict. If something changes, the team can regroup and get back on the same page quickly. It allows us to anticipate each other's needs, which makes care smoother and safer. So for example, if you know the provider is going to want labs before changing a medication, you're ready to have them drawn. It can prevent errors because we aren't making assumptions or guessing what others are doing. So imagine a patient is suddenly short of breath. If the shared mental model is strong, everybody already knows their role. Somebody calls respiratory, somebody grabs the crash cart, somebody gets a set of vitals, and somebody else updates the provider. Nobody has to ask, what should I do? Who's handling what? The team acts as a unit, not as a collection of individuals. A shared mental model keeps the team aligned, reduces mistakes, and protects patients, allowing us to provide safer, faster, and more coordinated care. So now take a look at a video on shared mental model. Okay, so take a really good look at this picture. So we have a group of people in full hazmat suits, clearly working on something serious. And then we have this guy, casually standing there in shorts, a pink polo, hands in his pockets, vibing like he just walked off of a golf course. So let me ask you, is this the picture of a shared mental model? Probably not. Clearly, one person is not operating on the same understanding of the situation as the rest of the group. So the hazmat team clearly has a shared mental model. They understand the risk, they understand the task, they understand the protective measures needed. Meanwhile, pink polo guy here is on his own planet, apparently. This is what happens in healthcare when not everyone understands what's happening, not everyone understands the level of urgency, and not everyone has the same information. And when this happens, patient safety is at risk. So a shared mental model means everybody's on the same page, they understand the plan, they understand the urgency, and they understand their role. So the moral of the story is, don't be the pink polo guy. So look at the images on the slide, and before I say anything, I want you to look and ask yourself, what do you see? You might notice something interesting here. So on the left, I bet some of you see two faces, while others see a vase. In the middle, some of you might see a duck, others see a rabbit. And on the right, some may see a young woman and others see an old woman. Same images, different interpretations. Nobody's wrong. We're just seeing it through our own perspective. And this is what can happen with healthcare teams. Two people can observe the same patient situation, the same vitals, the same conversation, and take away two totally different understandings because we bring our own experiences, our own assumptions, and our own mental models. This is why communication matters so much. If we don't check in with each other, clarify, and make sure we're on the same page, we're basically looking at the same picture while describing two different things, and that's when errors happen. So when we talk about shared mental models, we mean we have to slow down and confirm that we understand the situation in the same way and not just assume. So next time somebody says something and your brain goes, wait, that's not what I see, don't stay quiet. Make sure you're sharing the same mental model. So cross-monitoring is basically watching each other's backs to make sure our actions are consistent with the plan of care. So it's not about policing each other or judging one another. It's not about mistrust. It's about protecting the patient and protecting each other. In healthcare, we know things get busy, stressful, and fast-paced. So when this happens, mistakes or misunderstandings can slip in even with the best intentions. So cross-monitoring is how we catch issues early before they turn into errors. So how do we do it well? First, we make it normal for team members to watch out for one another. It's not awkward, not personal, just standard practice. So we ask questions to confirm the plan. Something as simple as, hey, just to double check, are we giving insulin before or after the tray arrives? We speak up when something doesn't look right. It can be a gentle cue like, I might be wrong, but I want to make sure we're still following the plan. Can we check? And whenever possible, we include the patient in on what's going on. Patients can often tell us when something feels off, and they want to be part of their own safety. The goal is team accountability without blame. If one person misses something, somebody else catches it. If I make a slip, you help me, and I'll do the same for you. So now you'll see a video on cross-monitoring.
Olivia, please get the non-rebreather from the cart. Jay, please call 911. Tell them we have a possible MI or PE. Olivia, the non-rebreather is in the third drawer. Remember, Olivia, when using a non-rebreather, we need to use at least 10 liters.
Yep, got it. I increased it to 10 liters.
So in healthcare, when things get tense, fast-paced, or there might be a moment when something doesn't feel right, it is our responsibility to speak up, even if it feels uncomfortable, because patient safety comes first. And one tool that can help us with this is when we cuss, which stands for C, I'm concerned, U, I'm uncomfortable, and S, this is a safety issue. We need to stop. So you can think of it as a graded assertive tool. We don't just jump straight to yelling stop. We start small and escalate only if needed. The first penguin here says, I am concerned. It signals the team that something seems off, but you're calm, you're just raising awareness. The second penguin escalates to, I am uncomfortable. Now we're saying, okay, seriously, something is not right and we need to pay attention. The third penguin says, this is a safety issue, stop. This is where we halt what's happening and reassess because a patient could be at risk. The tool gives us a shared language, so no matter your role or level of experience, you have permission in the vocabulary to speak up. When it comes to it's a safety issue, stop, everybody stops and listens. It takes the guesswork out. Nobody has to wonder how serious is this. Your words make that clear. If you see something, say something early. We don't wait till harm happens. We use cuss to get results before situations escalate. So here's an example of cuss being used in clinical practice.
Dr. Dean, I'm concerned about Ms. Keys. I'm uncomfortable watching these late decelerations, the baby's heart rate's in the 60s. I mean, I just don't think it's safe to continue labor.
So feedback is simply information that helps us improve. In healthcare, we all need feedback because the goal is always to provide the best patient care as a team. So there can be formal and informal feedback. Formal feedback is the kind that is planned and usually happens after an event. It's retrospective. We look back on what happened. It usually has an evaluative tone. So we're reflecting on what well and what needs improved. So examples are a yearly performance review, a case conference where we discuss a patient's care. Think of it as a structured type of feedback you can prepare for. Then there's informal feedback. This is in the moment. It's more ongoing and supportive, and it occurs during real-time care or right after a task. It's focused on helping someone improve immediately. So a huddle is a quick in-the-moment team check-in. It happens before or during a shift or situation to make sure everybody's on the same page. It's brief, usually a minute or two, and the purpose is preparing or preventing problems. It answers what's the plan, who's doing what, and what could go wrong. A debrief happens after an event. This is where the team reflects on what happened to learn for next time. It usually occurs after a procedure, rapid response, code blue, or stressful shift. It's focused on learning, not blaming. It answers what went well, what can we improve, what should we do differently next time. Informal feedback is often where most learning happens because it's timely and relevant. Feedback should never feel like criticism. It should feel like coaching with the goal of improving patient outcomes. We use feedback not to make someone feel bad, but to make the team better. So we will end with a video on huddle and a video on debrief.
Oh, this looks like it could be an acute MI. All right, everybody, hey, let's huddle up before we go in so we know what we need to do.
Well, I've got the 4 liters O2 by nasal cannula and 2 aspirins. He's hypotensive, so we might want to drop the nitro. He's already on the monitor.
Good catch, Karen. Hold the nitro. Where are his cardiac labs?
His labs are pending. We should have those in 15 minutes.
Okay, let's prepare to get him to the cath lab immediately.
I'll call the cath lab to confirm.
Okay, all right, let's get in there.
Hey team, that was one stressful resuscitation. Can we all take a moment to debrief? Okay, how did it go? What did we do well? What could have been done better? Let's recap what everybody did.
This is our first code in our new area. I came as soon as I could. Dylan was doing chest compressions.
Lee was working on the defibrillator, and I started doing timekeeping and record keeping.
Thanks for getting here so quickly, Chris, and for using situation monitoring so you could see what we needed help with. And then Dr. Benjamin arrived and took over as lead. And then Mario came over with the crash cart, and he was able to help me prepare medications, but I still needed a lot of help. Sue, you came in about that time and saw that we needed help. I think you just went and yelled, "We need help in here with CPR." Dr. Machado heard that and came in, and she was able to start working on the defibrillator so that I could just focus on meds.
It's a good thing Dr. Machado was in earshot. Why didn't the code team arrive to help us out?
This is my first time working in this area with a code. Unfortunately, the code line wasn't programmed into the phone, and I had to follow up with the operator. When I had called the operator, I was on hold for a long time. After the debriefing, I'll make sure I follow up so that doesn't happen again.
We definitely overlooked that, opening up this new area. Thanks for fixing that, Angie.
And thanks, Sue, for calling out to me.
At the start of the code, my compressions were a little too fast. Dr. Machado was able to give me that feedback, and I was able to correct and get back on pace.
Thanks, Mario, for checking back with all the meds given during the code. That helped with record keeping.
Thanks, Dr. Benjamin, for asking for my feedback on your plan to intubate the patient. Bag valve mask ventilation was effective at that point. I'm glad we intubated the patient after she got pulses back.
I'm glad I asked too, Sue. Does anybody have anything else to add?
No, I don't think so.
And now we have a plan to fix that phone problem that we identified. So great job, everyone. Thank you.